Yeah. Let's start.
Okay. Hello. Good evening and welcome to this session. This is going to be a very interesting session and different from the regular sessions that we have been having for last few days. And today we have Dr. Satish Khadilkar, who is past president of Indian Academy of Neurology with special interest in philosophy and spirituality. And today he will speak on consulting room, my behavioral lab, and he's going to highlight various aspects of patient behavior in the outpatient clinic. Dr. Satish Khadilkar, please.
Good evening. Can you hear me well?
Yeah.
Are you able to hear me well?
Hello.
Hello.
We are not hearing as well as.
Can you hear me well?
No, Sudhir, could you hear me?
Not clear.
Huh?
Not clear.
अच्छा. कारण सतीशचा पण आवाज क्लिअर नाही येत आहे.
I can hear you. Mishram, I can hear, and you can hear me, no? I think.
Yeah. Your is. सतीशचा आवाज बराच ब्रेक होतोय.
I think this has got to do with his internet connectivity.
Yeah. I think so. Satish, tuझं connection, is it a Wi-Fi and is it in the same room?
Yeah, it's next to the machine.
Oh. Anything else going on? Any other downloading or anybody else in the house using the net? असं काय आहे का? The sound is breaking.
आता येतं?
It's coming, but a little quirky. Let's see. I think you start. We'll see how it goes.
Is that better?
It is coming, but a
Is
little
that better?
slightly, but still not.
अजून ब्रेक होतोय.
Break होता है. What do we do? You want to? No, but the phone वरनं नाही करू शकत.
अच्छा, ते माईकने बरोबर येतो का? येऊ शकतो का?
That's Satish, can you hear us properly or you don't hear us also properly?
No, I can see you all, but I can't hear you well.
No, I think there's a connection.
There is a problem at your end.
Yeah.
Sir, do you think we can suggest him to use a different machine if it is available?
Do you have another laptop or a PC or something?
I can change the machine. I can change the machine and see.
I think do that. Do that.
2 or 3 minutes it will take.
Yeah, no problem. Stop sharing the screen.
I'll do that for him.
Yeah. In the meantime, let me see if we can just do some time pass. Just 1 second. What we'll do is I'll just 5 minutes. I'll talk something. Chandu, you want to say something till then? Dr. Mishram?
Yeah.
You want to say something till then? I'm just searching for one something. I can show that. Okay, here it is. 1 minute.
Leave the meeting and join this.
I understand what you're saying.
By the way, we found out what was wrong with Daniel Gold's connect that day. What went wrong? So he had what is called a VPN. So if you have a virtual private network, he was connecting through that. So we checked again yesterday. Now it was working perfectly. So I'll reschedule his talk sometime the next week. His slides are very good. His talk is very good. So it really got spoiled.
Yeah, but because of that delay, you know, the
It
whole
was
thing,
impossible.
you know, he was talking different and the video was showing different. So there was
No, it
no
was
fun.
impossible. We just could not do it.
Yeah.
And I found out what it is. I did another test yesterday with him. It worked today morning and it worked perfectly fine.
Yeah.
So we'll, now there's so many talks and things that I'm not able to schedule it. Okay, while Satish is doing, I'm going to take 5 minutes on a interesting topic. I'll just show it.
So just in case you also want to just see the questions once and if you want to take them.
1 minute. So this is not a medical talk actually. It's just 5 minutes. I'm going to talk on something which is relevant just now. You'll see what it is when I show the talk. Okay. You see my screen this time?
Yeah.
Okay. So this is now about sitting and how sitting is bad for your body. And there is now a new phrase. It's called sitting is the new smoking. So just as we all know smoking is bad for your body, but sitting is as bad and probably even worse. So this is they're showing how the person was there in 1990 when the TVs were like this. Now that you got these good TVs and a lot of internet and whatnot, and now even more with Zoom, people are sitting much more than they should, and that is dangerous. So there is a very nice book called Desk Bound by Dr. Kelly Starrett, and it's worth checking that book. How you should sit, why you should not sit, and if you do have to sit, how you should. It just tells briefly. So there's a lot of stuff on how sitting takes a toll, not just on your back. It is associated with increased risk of diabetes, heart disease, weight gain, chronic backache, and even cancer. So a lot of things have been associated with excess sitting. And so this Dr. James Levine from the Mayo Clinic, he's saying sitting is more dangerous than smoking, will shorten your life. It kills more people than HIV. Because nowadays HIV doesn't kill people, and sitting for as little as 2 hours increases the risk of heart disease, diabetes, and all those things I told you. And just because you go for an hour to the gym does not reverse the bad effects of sitting. So by going to the gym or doing exercises or doing 1 hour thing does not help. You should not be sitting. That is the important thing. So if you are sitting at work, you're sitting on the way to work, you're sitting in a computer, you're sitting on, you're all the time sitting. So what is wrong? The problem with sitting is that it seems so innocent and natural. Our bodies easily bend into that shape of sitting. And if you sat with perfect posture for 15 minutes, it's not bad. But like eating potato chips, once you eat one chip, you can't stop at that. So same thing is with sitting. Once you sit, you don't sit for only 15 minutes, you sit much more. And there is a concept called non-exercise activity. So what you do when you are not exercising the rest of the day, so whether you're standing, walking, gardening, cooking, catching an elevator, all these things burn up calories, and that is very important. And when that is not burnt, then there's a risk of obesity. So you have to follow 4 simple guidelines. Reduce all optional sitting in your life. Whenever you can avoid sitting, avoid it. For every 30 minutes that you are desk bound, if you sit for 30 minutes, move again, get up, walk for at least 2 minutes, and prioritize the mechanics, how you sit, the position. And there is what is called daily maintenance. So do preventive exercises for your back. So what is the guideline 1? Reduce optional sitting. So sit only when necessary. In your clinic, try to reduce sitting, try to have, keep walking from one place to another. Don't sit in your chair and, keep talking to patients. So work is the biggest opportunity for change. And now abroad, they are having these standing desks. So they are having a change in the work pattern where they have standing desk and you work while standing. And you look for ways to eliminate sitting from your leisure time. So like watch TV on the ground, you do stretching, squatting while doing that. So as you said, kill two birds in one stone. And if you do have to sit, then sit in the best possible way. We'll see how to sit. So 10 ways, then various ways. Take a walking meeting, do a standing meeting, keep, eat away from water, drink a lot of water, because then you have to keep going to the loo all the time. So make sure you don't sit continuously. Then guideline 2, for every 30 minutes that you sit, move for at least 2 minutes. So that move can be just walk around, go to the toilet, or do some squats or move your legs, just do something. Constantly change your position even when you are sitting. Don't sit in one position. And every time you sit, reset the body's mechanics. And I'll see what is that mechanics. You can put a timer on your phone that warns you that half an hour has gone. Then optimize the position and mechanics. So how you should sit, there are ways that you should bend. How you bend, how you squat, it's very important when you're tying your lace or you pick up something on the floor. It's very important you learn how to do it. You do the proper mechanics because your trainer tells you how to do in the gym. But then at home when you have to pick up, you forget that and you just bend in your back. So be careful. You do the same thing that you have been doing. And then do 10 to 15 minutes of daily maintenance. So you have to do exercises and things, whatever, to protect your back. So there are lots of, Satish has come, so I'm just rushing now. So there are lots of consequences of poor posture.
Can you hear me now?
Yes, we can hear you now. Good. So this is a rounded spine.
Yeah.
You should not be having this spine. This is an arched spine. You should not be having this also, lordosis. And you don't want a side slouch. You don't want one side tilted. So how to get the natural pulse? So how to organize it? All these things are there on the net. You just look for Dr. Kelly Starrett, and you have to pull in your abdomen and make that stiff. So the abdominal muscles are very important for doing well, for keeping your posture. And how you walk, that is also important. This is called hinge. Those who do gym, they'll know what is the hinge and what is squatting. So these postural principles you have to keep in mind when you are picking something up from the floor also. This is how you have to pick. Don't bend your back. And dynamic workstation also there. So again, if you do have to sit better. So not hyperlordosis, not rounded, but like this. And the bracing sequence is there. You squeeze your butt, you pull your rib cage down, get your belly tight, and then sit. And you try to maintain this so-called neutral position every time you're sitting, standing. And 3 golden rules again: sit with a neutral spine, get up and walk every 20 minutes, and do this maintenance work. Sitting on the ground is good, but we can't do that. Lotus posture or cross-leg, you can't do that. So if you do have to sit, then this is a good position. And when you sit in a chair, this is how you should be sitting. We have been taught that sit far back in the seat. You should not sit far back in the seat, because then you are going to sit with your back curved. Sit in the front edge and make it like a wedge. So this is how to sit and how to stand. I'll post this talk and the PowerPoint later on. We'll not eat into Satish's talk. Thank you. Satish, chalo.
Hi. So share screen.
Yeah.
Yeah.
Yes.
Can you see these slides?
Yeah. Now it's perfect.
Yeah. Can you hear me as well?
Yes.
Yeah. Great. So good evening. And I think there is so much of heavy discussion going on in all our groups and everywhere that Sudhir told me that do something light. So I've chosen something that is light, and I think you will all relate to this presentation. So basically what we're going to do is, I'm going to take you to the consulting room where we spend so much of our time. And I'll try and tell you some of the patterns of behaviors that I saw in the consulting room. And I think as and when you think there is some pattern that you have seen, you either raise your hand or ask Sudhir and we can discuss them. And then we'll see why these patterns work like that and what do they mean and what do we gain from them. Yeah, so let's start. So basically, I think there are some things which I have found extremely interesting, and I would actually like to know how many of, in my room, I've got 3 chairs in front of me, and I do not have any other chairs. There are just 3 chairs in front of me, and generally my secretary tells them that 3 people should come in, patient and 2 relatives. As soon as they come in, I find that the patient moves his chair and comes on a side and wants to sit close to me. This is something I've never understood. I've kept the chairs deliberately facing me. There is no chair next to me, but they will move and the patient will want to sit next to me. That's almost invariably, that is what I find. The next is, whatever my secretary says, a lot of people will come in. 3 or 4 people will want to come in, 5, 6, 7 at times. And once they come in, they make their room their own. They will stand wherever they want. They'll pull whichever stool and whatever, and they'll sit wherever. There are some guys who want to stand in a corner of the room and they want to observe what is happening. They are actually wanting to stand behind me, and often I need to pull them in front of me. Say, look, I don't have eyes in my back, come forward. How much ever you tell them, they'll keep their cell phones on. Often, depending on what socioeconomic strata they come, the 2 or 3 telephones they keep next to you. They will not turn the ring off, and they will want to take the phone, and they'll go out and they'll come in. And once they come in, they'll again start saying whatever they were saying. Once you sort of make them settle down in their own places and their phones are off and everything that you tell them they should do. Telephone is something that I find very, very annoying. I don't know how many of you find that. But if some phone rings or somebody takes a call, then it really disturbs my chain of thinking. Then you start with the history and you want to actually listen to what happened to them and how did it happen and when did it happen. But so often they'll start by telling you the diagnosis. They'll say, sir, I am a patient of myasthenia gravis and I'll come to you. Give me a chance to make my diagnosis. But they'll start with the diagnosis. So over the years, I've learned to tell them, look, don't corrupt my computer. Just feed in the correct information and I'll see what the diagnosis is. The other thing that I find very difficult to comply with is that as soon as they come in, without telling you, they'll connect you to somebody, either a relative who is not present, who is important, or a medical relative or a paramedical relative. I'll say, "Saab, pehle isse baat karo." You've not even seen them, you don't know the history, you are wanting to make a diagnosis, and they say, "Nahi, inse aap pehle baat karo." So that is something that regularly happens in my consulting room. Then when you tell them, okay, tell me what's happening and what happened to you and what are the problems you're facing, they will not concentrate on what is happening to them. They'll concentrate on where have they been, whom have they seen, how it hasn't helped them. साहब इसको भी दिखाया फायदा नहीं हुआ, फिर उसके पास लेके गए, उधर भी फायदा नहीं हुआ. You feel like telling them, look, by changing a doctor, you don't change the disease. No, the disease is the same. But they'll keep on narrating. You have to continuously bring them onto the line saying, look, tell me what's happening to you. Don't tell me where you've gone. Don't tell me what have people said. But just tell me what's happening to you. This I find over the 20, 30 years that I've been doing this, I have found this phenomenon increasingly getting common. More and more people want to just tell the diagnosis and where they have been. Some are tired of seeing doctors and they'll only put their file in front of you and say, Sab, isme sab hai. They don't want to tell you what's happening to them. They'll say, ye file mein sab hai. Aap ye file dekho to aap samajh jayenge. Then you have to again tell them, no, I need to listen to you, what's happening to you. So it's the files, where they have been, what all has been their journey and how it has become fruitless. There are one or two other points that in the consulting room, these are some of the recognized patterns which I find very interesting. Often someone else will start telling the history. Usually when there is a husband and wife, the husband will start telling the history and he'll give you all the details. When you, in between you say, look, why doesn't she speak? He'll say, no, main batata hu na aapko. I know everything. I think that point I find extremely important because that tells me what is the problem. I don't need to listen to the symptoms much then. When the husband insists that he has to tell the whole story, you know what is the problem and who is the problem. Some patients write down what they want to say and they'll read it from notes, which also can become very difficult because some people bring 3 pages notes, 4 pages notes. But these are the recurring patterns that you see in the history taking in your consulting room. Well, you've taken whatever you could take, you take the patient to the examination table. This is a reasonably new phenomenon. Then all 3 or 4 relatives will get up with the patient and stand next to you in the consulting room. You have to tell them, look, Baba, jara baju mein khade ho jao, I need to examine. I don't know why they come there. I don't know what they want to do there. If a patient is incapacitated, it's fine. I mean, you need somebody to help. But the patients are okay and they want to come and stand there. The other very interesting thing that I found in examination is that the most important part for them is the blood pressure, stethoscope on their chests, and if they ask, shall I remove the shirt? You have to say, yes, you remove the shirt. Otherwise, doctor ne barabar se dekha nahi. I think we have this very interesting fixation with blood pressure and the heartbeats. Everyone wants to check his or her weight. If your weighing scale is not there, you are not on that day. Everyone wants to stand on the weight scale. And then everyone says, oh, kitna jada bad gaya hai. Even those who are underweight say ki nahi, mujhe kam karna padega. So there's a continuous obsession with the weight that I see. Most interestingly, after the patient has seen his weight, a lot of relatives say, Sab, jara can I see my weight also? You have to say, chalo, aap dekho. Then they will want to say, mera jada hai kya, mera kam hai kya, mera height itna hai. And from time to time, they will say, Sab, bahut din mein BP nahi dekha hai. I am a BP patient. Will you mind checking? So in examination, these are the things that I think happen again and again. Then you examine his reflexes and what have you. I think it's a good idea to examine with the tuning fork because a lot of the times, besides neurologists, no one uses the tuning fork. So when you use the tuning fork, they feel, barabar se dekha humko, sab bol, ye machine laga ke dekha, wo ye karke dekha. So I think it's a good idea to use the tuning fork. Now the patient comes back to the chair after you examined and taken his weight. Invariably, now about weight, I must also say, and I would like to ask Sudhir and Chandrasekhar. After the examination is finished, I check the weight and I immediately write it down. Because if anything else happens, I forget the weight. Does that happen to you, Sudhir and Chandrasekhar? When he gets up for examination, he wants to first check weight. I tell him, no, first you finish, then I check your weight because I will forget his weight if something else starts immediately. Right. As soon as the patient and the family goes back to their respective chairs, immediately they start asking questions. They do not realize and they don't give me any time to write down what I found. Saab, ye aisa kyun hota hai? Kya diagnosis hai? They will not give you even a second because they do not realize that you have to formulate what you've seen, you have to write it down. not a small proportion, but a reasonable proportion. After everything has been done and you started writing down, they will tell you a new complaint. And the new complaint is often so important that you again say, "Arey Baba, ab tak kyun nahi bataya?" नहीं साहब मैं बताने वाला था लेकिन आपने एग्जामिनेशन के लिए memory failure. Then you have to again start with the orientation and everything. Right. Then we come to the prescription. You examine, you tell them what you think has gone wrong with them, and you come to their prescription. After you've written their prescription, a lot of them will say, please write in Marathi. जरा मराठी मध्ये ब्रेकफास्टच्या आधी ब्रेकफास्टच्या नंतर ते मला लिहून द्या. After you written it down, they'll pass it on to a relative. They'll say, तू बराबर से समझ ले. So that fellow again goes over the prescription. ये पहले क्यों है, ये बाद में क्यों है. And some of them can go to great lengths about information about which I don't know. For example, खाने से पहले लेना है, पहले लेना. कितना पहले? 15 मिनट, आधा घंटा, 45 minutes. Can I take it with other tablets? Can I take it with milk? Can I take it with warm water? Can I take it with cold water? Answers to them, actually, I don't know. So whatever is in my mind at that day, on that day, I tell them. So usually one more relative wants to understand it. And a lot of Indian people, a lot of our people, particularly ladies, will make it a point to say कि मेरा tendency allergic है, मुझे हर दवा से एलर्जी आता है, एलोपैथी का दवा चलता ही नहीं है. So that's a rider that they put so that you have to keep your antennae up. You see this all the time. मेरे को दवा चलता ही नहीं है, हेवी दवा नहीं देना, मेरे को बहुत छोटा डोज देना. All this they preempt you. When the consultation then seems to be over and you're given the prescription, then the relatives say, जरा इसको बाहर बिठाए क्या? इसको बाहर जाने के लिए बोलते हैं. And they think that there is something that you haven't told the patient that you want to tell now. And in so many patients, there is nothing that you actually want to tell. But they say, नहीं, अभी इसको बाहर भेजा है, अभी just tell us now what is the truth, as if you are not telling the truth when the patient was inside. When the disease is bad, like motor neuron disease, what Bursani always tells us, relatives say, usko mat batao, wo weak hai. You tell us, you don't tell the relative. So, patient ko bahar jaane do, baad mein fir humko batao. This again comes up with, and I think as you become more and more senior and more untreatable cases come in front of you, this happens with every alternate patient. They don't tell the patient, tell us. Then most of the families I also find they don't want to get up. They have to make use of the full time that they got from you. They don't want even a second less. And they will wait till sometimes you get up and say, okay, the consultation is over. As they get up to leave, they'll say, sir, very sorry, but जो भी सब आपने अभी बताया, वो short में बाहर जो एक अंकल बैठे हैं, उनको बताएंगे क्या? He is a very important family member, but वो अंदर नहीं आए. So will you tell him again? So often that other fellow will come in, and if you refuse that, they'll feel very bad about it. Right. Then we are coming to the last part of the consultation. And that I find the trickiest part, because this is where the patient's expectations are rather very high. Usually people come from out of town, they see you, they will say, they expect कि सारे टेस्ट तो अभी हो ही जाएंगे ना, रिपोर्ट लेके हम शाम को दिखा देंगे आपको, हमारा शाम का ट्रेन है. They want an EMG report, they want an MRI report, sometimes they want a muscle biopsy report, sometimes they want everything so quickly. And they think it's a part of routine because they have come to a tertiary care center in the city of Mumbai. Everything will be done in a jiffy. So that is something that you need to sort of slowly break to them, that some tests take time, some whatever. And the last part of the consultation. Even if you have made a very good, successful consultation, the end can be disastrous when these questions are asked. And these questions are asked so often. I'm sure I can contact you whenever I require. Midnight में भी phone कर सकते हैं ना आपको. They think that it is a given that you will be available once they have given you consulting fees. You will be available to them all the time. आपका सेल फोन नंबर आपके प्रिस्क्रिप्शन पर नहीं लिखा है सर, सेल फोन नंबर चाहिए. फिर रात में कुछ हो गया तो आप आएंगे ना. So this is the end of the consultation. That's a disaster. When you have made a very good diagnosis, you may have told them everything about the disease. They might be very happy with what has happened. The end is always trouble because they want to contact you as and when, and they want a promise from you that you will do that. Now, these are some of the things that I see again and again, which I have put down as patterns. Now, what do these patterns mean? And I'm sure in all your rooms, the same patterns repeat with a little difference, which is regional, little difference of one seniority or place of work or whatever. So I think these patterns are generally constant. What do they mean? So the title that I've given for this talk is My Consulting Room, My Behavioral Lab. So with every consultation is an exercise in behavioral interaction with the patient and the family. Each one is different, and from each one we learn. So what are the things that I have deciphered from these patterns that I have seen? This patient taking his chair close to me, many relatives coming into the room, patients keeping cell phone on, rushing out of the room for phone and all that. I think this is social conditioning. A lot of general practitioners see so many patients that they keep the patient's chair next to them so that they don't even have to get up. They will just take BP from there, put stethoscope from there, and the next patient comes in. So patients believe that that is how medical consultation is. So they'll move the chair next to you because I think that's the GP effect in India. Why so many patients' relatives come? Because a specialist consultation means a lot to them. Particularly they've gone to another city, they have seen somebody whose name they have heard before. That is a special occasion for them. So everybody wants to come, everybody wants to come in, and everybody wants to actually participate in that consultation. So as a physician, you find that intimidating. You don't want 10 guys to come in and stand next to you. But the psychology behind that is they've come for a particular occasion where a lot may be known about the disease and therefore everybody wants to be present. And about the cell phone thing, my feeling is that except for the doctor's room and the medical premises, everywhere else, humans are entertained. You go to a hotel, you go to a movie, you go to wherever, you are the king and you are entertained all the time. So I think we got all used to being entertained all the time. So this is the effect that they do not realize that they have to keep their phone off. They have to keep, only 3 people can come in. They think that's just too much. And about these guys who want to stand in the corner of the room, I'm very intrigued by them. I don't know why they do that, but there are some who go in the corner. This happens in the wards also. In the ICU, when you come out and want to talk to relatives, they won't stand in front of you. One will be to the left, one will be to the right, one will be in front of you. Some will be so far away that they're only observing. I don't know why they spread themselves out like that. And then one question comes from left, one question comes from the right. I think some of those guys who are sitting quiet are the ombudsman. They want to take the role of the ombudsman to see how the consultation went as a neutral observer. They often don't participate and they stand in the corner of the room. These are interesting ones. Right. Then patients starting by telling you the diagnosis, insisting that you speak to the doctor, narrate all the details to where they've gone, insist that you see the investigations, is their way, actually their way of telling you how much they have done already before they have come to you, and all that they have done hasn't helped. So a lot of them are not actually trying to show off how much money they've spent or how much they've done. They're actually trying to tell you that, look, it seems to be a difficult situation for us. We've done so much, but it's not working. So actually it's a plea for sort of looking at the case more in more depth. It's not anything else. Also, I think who tells the history, whether the patient writes things down, also gives me a lot of insights. So often you see this situation that there is a 5-year history of headache and the lady is only sitting and the man starts talking, iska bahut sar mein dard hai, subah mein, sham ko hai, idhar hai, then he'll show on her head where the pain is. You know that he is the cause of the headache. You don't have to really worry about anything else. So I think in a medical consultation, besides all this, what you're observing makes, it tells you which way you have to proceed. And their history narrated by someone else, one particular relative taking the charge of the whole thing and say, isko admit karna padega kya karna padega, tells you how is the social structure of the family, what's the interrelationship, who's the chap to be spoken to later on. So I think these aspects of the history, the way people go about, is actually to tell you that, look, we have already done a lot before we have come to you, and please try and do something for us.
1 minute, Satish. Keep
Yes.
the same way. I think one more reason why people tell their diagnosis, why they want you to see the reports, is people do not know how you make a diagnosis. They feel
Correct.
that the diagnosis is done by seeing the test. They feel the diagnosis is, see, for us it is logical that sometimes I tell it and it sounds mean that he says, ते आधीच्या डॉक्टरने असं सांगितलं, म्हटलं हे बघ आधीच्या डॉक्टरने ट्रीटमेंट नाही, हॅव यू फेल्ट बेटर, नो, देन डोंट टेल मी व्हॉट ही सेड. But that is sometimes being rude, but they want to tell ki that guy said it is
Correct.
this,
Correct.
that guy, this is the diagnosis. When you say what is your problem, they say I got spondylosis. I said what is the problem? Actually it is he's feeling vertigo, but he said I've got spondylosis. So when you
Correct.
say they do not understand how we
Yeah.
make a diagnosis.
Absolutely correct. Absolutely correct. Also, I think what is important to them, they put it to you, thinking that that will help you. Like if an MRI is done, MRI is many thousand rupees.
Yes.
They want you to see each plate. They want you to see it again and again. They want you to discuss it with the radiologist, because to them, that's the thing that will make the diagnosis. Yeah. Okay. So these relatives crowding around the patient, I have found it a little disconcerting actually. I really don't want them to come and stand behind me and keep crowding me. But I think that's the, again, a social conditioning and the general distrust that we see nowadays. I think this is a reflection of that. Also, the effect, the blood pressure and the weight are two very, very important things for Indian patients. Like, there are patients whom I have taken on the table as a neurologist, taken the blood pressure, and the patient has said, oh, okay, thank you, come down from the table and wanting to sit down, not realizing that blood pressure is not the only thing that neurologists check. So it's gone so deep in their psyche that when, again, a general practitioner related thing, that you take them on the table, you check blood pressure, and that's it. Right. Now, I think this part, I 100% agree with the patients. Even though it's a very annoying thing to write it in the native language and to speak to another relative to discuss it, I think here I'm 100% with them. And I think a lot of us do not spend enough importance, don't give enough importance, don't spend enough time on the prescription. And a classic example is anti-epileptic drug. We say follow up after 3 months. How many of us actually say, look, these drugs are not to be stopped. If your next appointment is 3.5 months, you don't stop them. Till you see me again, you don't stop them. I think we just say 3 months and come back. So a lot of them take for 3 months and they come back. So I think in medical prescription, maybe because of lack of time, the number of people whom we see or the way we are trained, I actually, when a patient comes back with a mistake, I find that half of the times it is our fault. Anti-epileptic drugs being stopped, corticosteroids being stopped. Also, people have these things in their mind, that from somewhere they know that epilepsy medicines have to be taken for 2 years. That's for blanket for everybody. So once 2 years are gone, they stop it. But okay, they don't do the right thing. But do we tell them, look, you are not going to stop till you see me again and I tell you to stop? Your case may not be 2 years, your case may be more, whatever.
This has become a little easier now with the electronic prescriptions.
Yes. And I think we should adopt to them, because I think this clarity is really required for them. And a lot of us don't write in legible handwriting. So that's an added problem.
Even you write analgesic SOS for migraine, but you have to write, don't take more than
once a week. Otherwise, they'll take 2-3 a day, day after day.
Medication overuse headache, and you have not told them.
A lot of times I find that we are in a way at fault because we do not take enough care to explain to them what they should be doing or they should not be doing. They're not supposed to know it straight off. It's often lack of time, but also lack of intent, at least in the way I see things. Now, allergic to allopathic medicines. This is a very interesting thing, and I don't know what it means. But my feeling is that each one of us is special, but also wants to feel special. So they have to have that something unique that's different from others. And that's what makes them say, "Humko dawa chalta nahi hai." Now, if you come to an allopath and you're going to say that allopathic medicines I can't take, then why have you come? But this is an expression of feeling special and wanting to be treated special.
Maybe it's also sometimes, I mean, I don't know, this the psychologists may frown upon me, but sometimes some people feel the need to remain sick. They don't want to get better, and then
I'll come,
they are preempting
I'll come
you,
to that.
you know? So they are if you so
Very
sometimes I ask them, okay, if somebody initially has to get irritated if somebody said allopathy nahi chalta hai, so then I would say, okay, what do you want from me? What can I do for you? I tell them that I can only prescribe allopathic medicine. What exactly do you expect from me?
Yeah.
Sometimes that makes it a little easier. Then they say, to come dose deo or something. Then you at least
Correct. Correct. But I think it's a need of feeling special, feeling unique, whatever. And in this group of patients, and this group of patients is not small in India. These statements that you have a very rare disease, they are happy. I mean, I can't understand this, but you say कि ये 5 लाख में एक को होता है बीमारी, खुश हो जाता है कि मेरे को rare बीमारी है. I think it's again a manifestation of feeling special. When somebody doesn't respond as you think he or she will, or somebody thinks, look, I'm not responding. If I say, look, your response to this particular illness seems quite unique, and most people will have different response, they seem happy with it. I think it's more to appeal to their psyche rather than anything else. These patients who are allergic to everything, I say, look, I have to think very hard what to give you because you are allergic. And maybe we shouldn't give any medicine. We should try meditation and yoga and this and that. And they say, nahi saab, thoda dose de do. You give a little bit, but give the tiniest of the dose that you can give. So it's all in the head, as you say, Sudhir. But I think in a lot of our people, particularly those who do not have very, very serious or handicapping illnesses, there is a need to feel special because there's a need to appease themselves. And it's like those of us who have held medical conferences, we know that nobody wants to come in as a simple delegate. Everybody has to be a chairperson or whatever. Similarly, every patient, there is no ordinary patient. Every patient in your consulting room is a special patient. Right. Then I think the last bit, the test should be done immediately, and I have to see you because I have a train, and can I contact you all the time? I think these, quite frankly, are unrealistic expectations from practitioners of medicine. And it's not our failure, it's a system failure. One individual, it's individualized medicine that we still live in India. And one individual really cannot cope up with these demands of medicine. And therefore, I think there is an absolute need to do what rest of the world has done. Have a nurse practitioner, have somebody in between, somebody who can answer simple questions, which none of us seem to have done as a system or as individuals. They may not be it may not be too difficult to do it on an individual basis, but I think that's something that we need to look at, because a good patient contact turns sour because you cannot provide what they want all the time. Right. Now, a lot of consultations go well with experience because you can attend to the sharp corners. But some patients come into your room with an idea that whatever you say, they want to negate it, or they want to turn it down. They want to say कि ये काम नहीं करेगा, ये चीज से फायदा ही नहीं होगा. And I think there we need to understand that being unwell or being in pain could have taken its toll for a long time. Long waiting times. A lot of us who have become senior, and as we all become senior, the waiting time increases. And there was a patient recently who told me that when I took your appointment, I was having headache. Now, by the time the appointment has come, there is no headache. So the waiting time that they have spent before they have seen you, because of the disease, the substance abuse, the anxiety and distress of the unknown. Like we are in COVID, we don't know what will happen. See how anxious our group is, continuously throwing more anxiety and more anxiety. And previous poor experiences. That I think plays a lot of role. Like somebody has taken phenytoin, has developed a rash. Whatever you give, he's not going to be comfortable. So you need to take into account all these. And lastly, the guilt. Lastly, the guilt. A lot of people and families feel that they should have taken the patient to you earlier and they haven't, and they are feeling bad about it. So all this makes a consultation challenging from time to time. But I think as medical practitioners, we need to remember that ours and patients is an unequal partnership. It's not one-to-one. We definitely are in a better position than him. We do this thing only every day. So I think we need to understand these problems and therefore raise ourselves to a point where it doesn't become a free-for-all. And this is very important, that we do not let our decision making or our diagnostic acumen being swayed by these factors, because there are lots of studies, and I've quoted one recent one here, that a patient's behavior influences the accuracy of doctor's diagnosis, because we are also human. We get affected by what's happening. We get affected by the way they speak. We get affected by what happens in the room, and our diagnostic performance changes. And I think it's one of the measures of our competence is not to let it sway depending on how they present. Okay. Now I'm coming to the last part of the slides. With the patient's behavior patterns and my analysis from it, what I think is the crux of the medical consultation. The real crux of the medical consultation is that very quickly it becomes you versus him, but you have to, it is not actually you versus him, it is you and him versus the ailment. And I think this is the crux of the medical consultation. Very quickly it becomes you versus him. Like the patient will say, क्या साहब दवा दे दिया, हमको तो कोई फायदा भी नहीं हुआ और महंगी दवा थी. It becomes him versus you. Now, his non-response to the medicine is not your fault. It's the way his body is. So I think first of all, if you can convince yourself that it's not you versus him, you're not going to look at him as a litigant all the time. You're not going to look at him as somebody who is opposing your views. If you can believe that, and if you can make them believe this fact, that it is not you versus him, but it is you and him versus the ailment, I think you make a successful medical consultation. I think that is the single most important crux of the medical consultation. You are an expert. You got your DM degree. You are a certified expert. But to do a good medical consultation, it's more the healer, the friend, the philosopher, and the guide who is also an expert. So I think this, our role we need to identify very quickly. We say, is this going to be a troublemaker? Will he do this? Will he do that? Why is he saying all these things? By getting into that mode, you're actually letting go of this chance of impressing on him that you are on his side. We're actually on their side, but very quickly we can go on the opposite side. And I think each consultation is unique. There is no standard protocol. There is a protocol for diagnosis that we have, the brisk reflexes and the extensor toe and what have you. But I think we neurologists have been trained too much in the art of diagnosis. We've not been trained too much in the art of therapy and very little about understanding the human beings. So we need to understand the disease as well as the person who has the disease. We're not diagnosticians alone. That is what we've been traditionally been labeled as. Our therapy is far more than pharmacotherapy. And I think when the patient leaves your room, he has to feel happy and less burdened than when he came to see you, and not knowing all the things that are wrong with him. For example, you have a patient who has a cholesterol of 230 and a blood pressure of 140 by 90 and a uric acid of 8.9 and ventricular premature beats and whatever. Giving him a list of what is wrong is not going to make him happy. You're going to have to say, look, all these little things are there, but they don't seem to be too big. He wants to feel good. Now that is where I come to your point, Sudhir. A lot of patients feel good when they are told that, look, there's nothing much wrong and they're okay. And this seems to be minor and they should take a little drugs. But I see a small group of modern Indians who are usually young, who are successful, who are quite burdened with what they are doing. To them, if you say you're all right, they're quite unhappy. So that's my statement. Last one. The modern Indian has to feel a little unhappy to feel happy. उसको थोड़ा सा स्पॉन्डिलोसिस चाहिए, थोड़ा सा वर्टिगो चाहिए, थोड़ा सा GERD चाहिए. ऐसी बीमारी चाहिए जो कुछ बड़ी नहीं है, लेकिन वो चाहिए. He has to use that cervical collar whenever he wants. So about a middle-aged and older person, tell them you're okay, go home, nothing will happen. They're very happy. But to a new modern Indian who is stressed by life, you have to say, look, there is a little problem, but you will cope up with it. So that makes them happier. So each consultation is unique. And this is from William Osler. A good doctor tends to the person who has the disease rather than just the disease itself. And we are all trained too much in disease and not in persons who have the disease. Because finally what we have to convince them is that healing doesn't mean that the damage never existed. It means that the damage no longer controls their lives. So I think if your consultation can do that trick, I think that's what we need to achieve at the end of the consultation by analyzing these patterns and understanding about them. And that again, I'm reiterating, is the crux of medical consultation. So actually I started the lecture off by saying my behavioral lab, because I thought I'm going to analyze behaviors of the patient. But in the end, I realized that it is my behavior that I need to alter. Their behaviors I can't alter. So it is actually my behavioral lab. So thank you very much.
Nice. Very nice.
Really deserves a clap.
Yes. So the thing is, you are very right that it is my behavior, because we, when you see a patient and you treat him, you expect him to be happy when you have cured him. And when the guy is not happy, he has some psychogenic thing remaining, or you get angry, you get a little upset as a doctor. You have done your job, you have treated him, he has no right now not to be happy. So many times we don't get that thing, that there are other things behind it, and it's the illness and not just the disease. So we have to, like you said, start treating the person also and not just the disease. There's too much focus as neurologists, we focus too much on the diagnosis. And like
Yeah.
Trying to write a book on psychosomatic illness, and I just wrote a chapter on the headache part of it. So there is the same thing that as a neurologist, when the person comes with an MRI normal, test normal, and you say, I've been having headaches for 5 years, your diagnosis is done. So you know it's a primary headache, and so you get turned off.
Yeah, yeah.
Like you think your role is that of a diagnostician, so that's done. I mean, there's nothing. So the worst thing you can tell to such a patient that you got nothing. It's nothing. So we have, that is where thing starts.
I'll tell one instance where how diagnosis overrides us. A boy came with a spastic gait and came in. I saw the spasticity, scissoring, and his father had it and his grandfather had it. So I knew that this is hereditary spastic paraparesis. I thought my diagnosis was made. I took him to the examination table, made sure that there were pyramidal signs and nothing else. I came down to write baclofen. He said, "Doctor, I know that I have this. I have come for my headache." So I think we get so zoomed in on the process of diagnosis. I think that has been a traditional fixation.
Yes.
Get the diagnosis.
Because I think as neurologists, what has drawn us to neurology is the puzzle solving thing and the problem solving thing, and where is the plantar and the plantar upgoing and the one eye not adducting, so it's a lesion there. So we like to diagnose, we like to place the anatomy, but we have not taught the psychiatric skills, the communication skills. Those have not been taught to us, and those we are learning now, as you say. From my lab, it is becoming my lab. You are learning yourself what to do.
Correct. Also, I think it's the same philosophical thing. You can't change others. You can only change yourself. So change your responses to what comes.
What do you think before we take the question answer?
Yeah, I think there are few things which are also important. Yeah, are you hearing?
Yes.
Yeah. So I think there are certain icons or certain people who are very successful in practice, especially in some of the homeopathic practice. They listen to the patient so much. They go into such details about everything, their family. Taking up that history part in homeopathy is so important, and people get very impressed by their communication.
But they get healed, not just impressed. I mean, it heals. So
it heals. They understand the psychology of the patient. The doctor who is successful, any successful practitioner, is the one who understands the psychology of the patient better.
Correct.
The homeopathy listen to the patients, and the Ayurveda people, they do for the patient. They will do this, they will do massage, they will do the, so many procedures on this. And, I will tell one of the examples that we don't do, or we don't do this checkup. One of my psychiatrist friend had referred the patient to me. And then I examined in detail, taken history, and, examined reflexes, fundus, everything. And then I wrote to him. And then he went to the psychiatrist. He said कि आपने बोला था वो सर के डॉक्टर हैं, तो उन्होंने सर तो देखा ही, बाकी सब देख लिया, हाइपर देख लिए, आके देख लिए.
This is very important. I tell this in my to the students and things. When a patient is coming to you for headache, you check his plantar, you check his fundus, you check his reflexes, and you don't even touch his head. That is not done. You have to touch, you have to palpate the head just to make him feel. In fact, if you are in a mood, auscultate his head. He'll feel very good.
Yeah.
And secondly, one more important thing, that unless you tell patient that you eat this and you don't eat this, they're not happy. This has to be a part of this, whether it is relevant or not relevant. But then you have to tell something that you eat this, don't eat this.
We call it pathya.
Pathya, yes, that is part. And secondly, talking to the patient in their own language. If you learn few languages, like if there is a Punjabi patient, I make it a point to take his history only in Punjabi. I will speak in Punjabi. If it is, Maharashtrian, I will speak in Marathi. So if you speak in their own language, they feel very happy about it.
Yeah, and I think you can get caught out. A Marwadi patient came to me And he said, "Aap Marwadi?" I said, "हाँ, Marwadi बोल सकते." I said, "बोलो." So he started talking, but he started talking in a dialect of Marwadi called Ghodwadi, and I couldn't. I said, "नहीं भाई, हम हिंदी बात करेंगे." So you be careful when you say talk in whatever language you want. Okay, let's take some of the questions.
Yeah.
How? Okay, so how do Dr. Dhruv Batra is asking, how do the senior practitioners identify crooked relatives of the patient who are looking for an excuse to create a ruckus and find fault with the doctor? That means he's saying, how should one deal with them and avoid controversy?
I must say that actually such outright people with outright wrong intention are very few.
Yeah, yes.
I think most have become that because of XYZ, and if we dispassionately see a lot of fault lies with us also. So I don't think there are too many who come with the idea of making trouble.
I also agree.
Once they feel that they are wrong done by, then the whole thing starts.
Yes. Okay. Dr. Arikapudi Haritha says, we connect so well with you, sir. What will you explain when a patient with stroke asks, when will my clots dissolve? Very common question.
Yeah. Particularly when you show the second MRI and it remains the same, then this comes up. I usually tell them that the brain cells that are living will take over the function of those that are dead, and your MRI will remain the same, but you will go on improving, and that's what we want. And that gets them away from the clots.
Yes. Do you face this problem in any disease which is going to improve, whether it's a stroke, head injury or something? The question asked is, cover kadi honar? When is he going to recover? So they want to know the date. The guy has got a massive bleed, dense hemiplegia, unconscious. They want to know ye cover kab hoega. So how do you tell them that he's going to improve, but not fully, not going to become like you?
Yeah, I think that's a Indian fixation, that 100%.
Yes.
Even 99% is not okay in their concept. But that is where I think this role of a healer, the last slide, that we need to make them aware that, look, the damage can't be undone, but it's not leading your life. So again, it's a lot of talking and
yes.
I think
but
people don't
are not easily happy.
At the same time, people don't accept the death. Well, even the patient is lying down bedridden for years together. They are happy about it. Majority of that is the psychology of Indian patients.
Yes, no, but that is often there. You see a very serious patient, you tell them kuch bol nahi sakte, kuch nahi this, that, whatever, aisa, and you come out and say, but sir, kya serious nahi na?
और सब तो ठीक है ना, और सब तो ठीक है ना. Like you come out of the ICU and tell them that half of the brain is not working and blood pressure is down, and they say और सब तो ठीक है ना.
That's Rup Gursani again.
Now, Dr. Ramamurthy was a very celebrated physician. I don't know.
Yes,
you won't know him, but he was a huge name.
Yes, Dadar.
So, this I've learned from him, that he would come out of the ICU and tell them what is working. जैसे यूरिन बराबर हो रहा है, creatinine normal है, SGOT, SGPT ठीक है. So they'll feel happy about it. If a patient has a huge cerebral hemorrhage, he will not tell about that. He'll tell about what is right, and he'll say, we'll fight. I think that is towards these terminal patients, that is something that I have learned from him and then from my own experience, that you can't say I'm giving up. You can tell them kitne pani mein hai, but then you say, look, I will fight. Otherwise, if you say, look, there are no hopes, और किसी को दिखा सकते हैं क्या, और क्या कर सकते हैं, दूसरे किसी को बुलाओ. So I say, look, it's not looking right, but I will keep fighting.
Okay, Dr. Guru.
Yeah, another thing, Sudhir,
yeah,
I think is sometimes the referral or second opinion. The patient goes to Satish or maybe Dr. Singhal and for over the years, and they come back so happy, meeting Dr. Singhal.
Dr. Singhal is a magician. You send, I mean, I don't know if he's listening, but you send a motor neuron disease to him and the guy comes back so happy.
Yeah.
Dr. Singhal will call you from there and say, Sudhir, I have explained to to do this and do this and sell it back. And they're so happy. First of all, but you must understand that sir spends at least half an hour with the patient. He'll spend a lot of time with them. He'll see all the reports. He'll see the ESR. He'll tell you that the sodium is a little high. So he sees every report and calls you. So the patient sees that he's really checked everything.
Yeah.
That is, I think, one of the...
And in the end, I will tell a story about that one of the patients.
Okay, Dr. Guru Prasad Hosurkar has asked an interesting question. He said, after learning the hard way of getting the family of the patient to end the consultation and make them get up from the chairs, now comes the turn of teleconsults. How to end the consults on video?
I think for the physical consultations, I get up and open the door. So it's easy.
I have done something easier. My teacher, Dr. H.V. Sardesai, he was a very senior, very good physician. So he had these 3 cabins, and you don't wait for the patient to get up. You get up and go to the next cabin and start seeing the next patient. So there's no question of them getting up. If you sit there, they will keep asking questions. But I don't know about teleconsult, what you're going to do. You can't tell them now I'm seeing the next one. So we don't know.
It's a new art.
We'll learn on the way. Dr. We'll learn on the way. A psychologist, Dr. Kinjal Goyal, is saying, I think she's a comment, not a question. I think it's commendable how you have adopted decades of frustration and metamorphosis has taken place, transforming it into brilliant and sensitive insight. So good comment for you. Then Nishit Patel is saying, sir, most of the times when the patient comes to me with a written list of the complaints and questions, he's likely to be a school teacher. What is your observation?
Well, he's systematic now. He's doing something that makes him systematic.
Then Dr. Kalyan Iyer said, hi, similar experience. But even when you explain medicine while writing the prescription, they will almost always go over it again.
Yes. I think they just want to be very, very sure. And I think they should be given their time, whatever time it takes, because that's the most important part of what you're doing.
Sucheta Mudgerikar is saying something. Satish, something that we ladies experience every time is all patients call us sister and never doctor. So, yeah, I remember in my clinic, I had a lady assistant doctor, and after she would see the patient would tell, sister, abhi doctor kab dekhenga? She was an MRCP, and they'll say, sister, abhi doctor kab dekhenga?
Yeah, so I think it's a social silliness.
Okay, then Dr. Shakib says that I think suggesting that patient wants a low dose drug is also because they're scared to getting used to the medication. A lot of patients are scared that once they are on a particular drug, they will be so for life.
It's also disease related. I mean, we didn't discuss that, but if there are movement disorder specialists, they will relate to this. A Parkinsonian patient comes in your room, he tells you 50 different things that are not okay. I'm not speaking loudly enough, and this and this and this. And then you say, okay, I slightly increase your dose. You say, no, don't increase.
Right.
So
right.
I think there is a disease specific thing also.
Yeah, they want.
Parkinsonian guys are definitely worried about overdose and the side effects that they see. So they'll narrate their woes, but they'll say, don't increase. Itna hi rakhta hai.
I suppose possibly part of it, they want to know that this is nothing serious. They want to tell you the symptom and get it past you. If you say that, okay, just increase the dose, they'll say, okay, fine, it's not necessary. Okay, then there's again something interesting. Dr. Rahul Kulkarni is asking, do you think having an assistant who can work like a medical clerk is a good option?
Well, I think it depends on, I mean, one of the problems here in our country is quality and quantity. You can very easily swing one way or the other. And trying to do both, an assistant can come in the way, but it has to, I mean, it can be of help, but it has to be very beautifully structured.
I'm allowing Rahul Kulkarni to speak. Rahul, you can ask what exactly you mean by
Yeah.
Clerk is a person who can take blood pressure, who can ask simple questions. He or she can write down the prescription for you, but he or she is not going to interpret the disease or give the diagnosis. It is just a medical clerk who will help you to relieve some of your stress in the OPD, like taking blood pressure, etc.
Why are you calling it a clerk? I have a houseman, like person who's with me, who's a homeopath. They take excellent history. She sees the patient, she'll write the prescription, then I tell her what I make the diagnosis, and then she'll tell the patient, explain everything, BP and all. So not necessarily clerk, but it's useful. It's very useful. So
I agree.
I think you should have an assistant in your clinic.
But I think this is an issue of, like I said, quality versus quantity. This can help you in the quantity, but then you need to pick out whom you need to do everything. Maybe it will help you to pick out those few.
See, so you will find that some person, even after the assistant has seen, will still want you to check the BP, will still want you to check the weight. Do it. If the person is not happy, as you rightly said, do it. If the person says shirt nikalu kya, nikalo. Only problem is when he starts saying pant nikalu kya, then I have to tell him, wo main uska doctor nahi hu, So, okay, then Dr. Sucheta Mudgerikar is again asked a nice question. You haven't mentioned the Googlers. The ones in Google.
Yeah. Actually, initially I used to get apprehensive about them, but now I like them because they know everything. So you can discuss with them. Actually, now I'm not worried about them. In fact, I think that they are much nicely prepared. Yeah.
Right. Okay. Then somebody says, excellent talk, should we inform to patients of MND about disease if relatives insisting for not to inform as he's very weak? So what do you do when you have that Kursani type patient?
Yeah, I tell the family that everybody must know about their diagnosis. When, how, and in what manner will depend on that particular family setting and that particular patient. So you tell me how this patient is, how strong or weak he is, and then I will decide how to. But I will tell the patient. Not at the first go, but soon I'll tell the patient. Everybody has a right to know what is wrong with them.
Okay, Kishore Shetty makes an observation. Sometimes patient feels happy if his disease is something which a famous person had. Yes, in myasthenia, it is nice to see that Amitabh had it and now he's become a crorepati.
Yes.
So you can. What about the relative trying to record? Dr. Dhamija says, what about the relative trying to record the total consultation? How to deal with them? I think you have to assume that somebody is recording anyway. You will not know it also. But if he's doing it in front of you, what do you do?
Well, actually, a lot of people nowadays record. And if they tell you they're recording, I don't mind it. Because then I know what to say. Because I'm anyway going to say what I think is right.
Yes.
Doesn't matter if he goes and plays it again at home.
I think the same thing. It's like Corona. Assume everybody who's coming to you has Corona. Like that, assume everybody who's coming is recording. Dr. Kishore Shetty is saying, when the patient with bad prognosis comes for repeat follow-up, MND or PSP, often with great difficulty, and you really have nothing to add, what do you do?
I mean, this is what I said. The crux of the thing is to make him realize and feel that you are on his side and you are doing your best. I generally tell them, look, I need to now, you're deteriorating very fast. I need to read more. I need to read again about whether I can give you anything, though often there is nothing more that I can do. But you have to get yourself on their side and they have to feel that you're on their side. They don't mind MND having no treatment. They want you to work with them.
Right. Okay. Anand Diwan asks another problem. How to deal with patients who do not get relief with treatment, but still keep coming to you for follow-up even before time, do not go to other doctors, but they are not getting relief, they are not happy, but they still want to come to you.
I think that's a symbiotic situation that develops over time, and this is not uncommon. That they will not miss their follow-up. They will not want to go to anyone else. And they don't mind the outcome, which they think is unsatisfactory. So they are also okay. I mean, you talk to them, you ask them what's wrong, and you prescribe what you think is right. Again, that's not a problem.
Yes, I think
most of the follow-ups actually don't need to come. But when you tell them, look, you now don't need to come, they want to come.
They're unhappy. No, but I think this patient who's not feeling well and still wanting to come to you, I think first thing you have to get your ego aside. We feel a little unhappy and angry when somebody says he's not well. So if you should feel happy that he's still coming to you.
Exactly.
So he still feels it is worth coming to you. So entertain him. You now it is accepted that he's not going to feel better. He also accepts that, but he still wants to come and talk to you.
Also think your best about him. You may find something.
Hemant Sant is saying, I thought only Puneri patients behaved in this manner.
It's universal.
Okay, Dhananjay Duberkar asking something which is, Dhananjay is asking, how do you deal with a functional patient? I think you told quite a lot, but Dhananjay, tomorrow we are having an interview with an author who is going to talk about how to deal with functional patients. So tomorrow's interview with Susan O'Sullivan, you should listen to. I think we'll do that. Okay, then somebody is anonymously asking, we physicians are so judgmental and mean. We should become aware of that. I appreciate your approach.
Thank you. Thank you. I think you're right. We have for a very long time taken the role of knowing everything and that the patient doesn't know anything. It has long since changed, and it is a health partnership. You only have to tell him the way which you think is best and let him decide what he wants to do.
Right. Okay. Somebody is asking an important question. How do you respond to a patient who has been treated wrongly by another doctor? And of course, and the next thing is that you have made a diagnosis. Suppose he's been treated as something XYZ and he comes to you and it is something very easily treatable which has been missed. How do you?
My first comment is such situations are becoming more and more uncommon. I think the general level of knowledge is getting better and better. And situations where something is completely missed is quite uncommon. But when it happens, I have found the best way to say is that what was done at that particular time was probably best at that time. And now we'll do this. Yeah. It sort of takes away the right and wrong. Yes. Because really we don't know what is right and what is wrong.
Somebody had told this that, you know, if you get a patient of Parkinson's and he's been going around with frozen shoulder and heaviness on one side for 1 year and taking all sorts of treatments, and he walks into your room and with even, you know, before anything, you diagnose Parkinson, and if you make that spot diagnosis, the patient is often very unhappy and angry because he says, if you could diagnose in 1 second, what was the other guy doing for 1 year? So instead of being happy, they get very unhappy. So you avoid this tendency for making a smart, spot diagnosis.
Correct. Even if you get it, I think you have to still start with the history and give time and
Okay, Dr. Kaumil Kothari asks, thank you for excellent talk. Can you please guide what exactly you say or do when patient asks for your number or how to contact you?
I give it to them nowadays.
Oh, you give it?
Because whether to lift it or not is still my choice.
So I tell them that if I give my patient to everybody, I will also fall ill. So I said, you have a problem. This is the clinic number. You have an emergency, you contact the hospital. But personal number, they understand. I mean, I don't know. I tell them that.
I find nowadays that I'm giving it to more and more and lifting less and less phones. So it doesn't matter.
I know you didn't lift my phone.
It must be a new number.
Dr. Muralidharan. He's saying, Satish, good observations. Like to know how much time you finish one consult.
It's completely arbitrary, as long as it takes.
Yes. Okay. Dhananjay Dubekar asks a very nice question. Sir, for what gives you more satisfaction? Correct diagnosis or happy patient and relatives?
Right. See, earlier on, it is making the diagnosis when you start your practice. But I think it fades rather quickly because then you realize that you're supposed to make a right diagnosis, you're supposed to give the right treatment. It is the happy situation.
Yes. And somebody saying it is time that we study Ayurveda and holistic medicine because we see so many psychosomatic patients.
Maybe.
See, one thing that Ayurveda, homeopathy, and most of the traditional medicines have done is they have not separated the mind and the body. In allopathic medicine, we have sort of tried to separate. A disease of the brain is neurological, a disease of the mind is psychiatric, which is not true, but it's a different. We'll see that tomorrow. Dr. Shubha Subramanian says it's become fashionable to say I'm allergic to allopathy. Do you think it's because of fixation with Siddha, Ayurveda, and alternative medicine?
It's possible because those people, that is their USP, that these drugs don't do anything wrong. So it's possible that that's how it is developing.
Suppose you have a patient you are treating, let's say stroke or something, and he's going to get better, he's going to improve. And then the patient says, can I give Ayurvedic medicine or can I give homeopathic? What do? I do a certain thing. I want to know what you do when they ask you, can I give same time?
I give a little bit of a preamble that I haven't studied that science.
Right.
And then I'll say, look, they haven't studied this. And then I say, look, you won't find somebody who has studied both. So if you combine both, what will happen? Nobody will be able to tell you. But with common sense, you can go ahead because I know that they will go ahead.
But see, what happens is I tell the patient that, look, I mean, this is always I joke and tell them, but I say that if the patient improves with what we do, the homeopath is going to take all the credit. And if any side effect happens, you are going to blame me. So I said, if you want to try homeopathy, you try that first. Then I tell the things that you said, that I don't know about the interactions between these two things. So it's best not to combine. You want to try homeopathy, take that first. And then if that helps, don't come to me.
Yeah. Yeah.
But in a hospital, you have a stroke and you are trying very hard and somebody comes, oh, can I put this homeopathic medicine through the ice tube?
I allow them.
Yeah, but see, you allow, but it's always a little difficult. Okay.
Yeah,
You break the untreatable.
Nurses don't like it. The ICU registrar doesn't like it.
Okay, Dr. Nitin Lovare asks, how do you break the untreatable or dead diagnosis to the patient or relatives in the first visit or over a couple of follow-up visits?
I think like Roop mentions about this, breaking bad news has become a science. It is slow.
Right. Okay, Dr. Jayant Pandey says, how many questions you want to take more? Maybe 5 minutes more.
Yeah.
A good neurologist is the one, Dr. Pandey is saying, a good neurologist is the one who understands working psychiatry very well as well. Hence, every neurology prescription should have appropriate drugs as well. This will solve many of his functional problems as well as the neurological ones.
Quite right. I mean, like some places like NIMHANS, there is a psychiatrist in the examiner panel. So some people do that.
Okay. Somebody is asking, is it legal that a patient records the consultation? Whether it's legal or not, they do. So,
yeah.
Okay, Chetan Chaudhary asks, mistakes are a part of practice. How to do counseling about mistakes? Should we admit it or hide it?
It's a very difficult question, but I think sooner or later people come to know what has happened. So, I mean, what is a mistake actually? Medicine is such a science, if at all it's a science, that there is nothing 100% black and 100% white. So you did what was best at that time. So it's not actually a mistake. It's something that didn't help the patient. So it's probably best to put it like that, that this is what I thought was right at that time. I did it. It didn't help you. So we go on.
Yeah, I think honesty is still the best policy. Okay, so PNES, somebody is asking, but I think that we got to. Okay, patient of first episode, do you tell them that you have to take anti-epileptic for the next few years at the first consultation itself? When you are starting first seizure, but probably we may not start for the first year. But suppose somebody has 2 seizures, do you tell them that juvenile myoclonic epilepsy, suppose that you are going, when you start the medicine, that you are going to have to take it for life probably?
The way I have found most convenient is that I tell them that my approach will be to give you medicines to the minimum period that is safe for you. And let me decide on that depending on how you go.
Good.
It's again the same situation. If they think you are with them, see, by saying that you want to give minimum period of drugs, you are with them.
Yes.
That works beautifully for them. Then you say, look, this seems to be a situation where I need to give it lifelong. They will not mind it over a period of time.
Praveen Nafre says, patient asks a permanent cure for migraine. What to explain?
I think like every consultation is unique. what all has happened in those 15-20 minutes will instinctively tell me what should I say.
Yeah. Somebody else again, Dr. Pradeep is asking, how do you explain when patient asks the mechanism or the cause of migraine? Okay, I think we'll take the last one. Datta Nadgir is asking you, epileptic gets married without informing you and the in-laws pose a real problem, but difficult to manage. Relatives want you to tell a lie. How have you managed such cases?
Yeah. No, I have kept a policy that I will say what has happened and what is there. Then whatever consequences come, I am willing to take them.
Right.
I've gone to the court so many times to give evidence, but what is there is there. I mean, what can you do?
Yes. Sometimes some of my patients has come and told me this got married. We are getting the in-laws. Don't tell them that we were your patients earlier. I said, look, I cannot do that. It's just not possible. It's best that you go to another neurologist and start as if it's the first time. But don't tell me to say that this never happened. Okay, I think Satish, this was a.
I think one important thing is
I think
we should not.
Society wants you to do wrong.
One should not get angry with the patient.
Yes.
I think.
Chandrasekhar, you wanted to tell one last case, something you said before you ended?
Who, me?
You said, na,
You wanted to say something. Yeah.
Some case
about Dr. Singhal's consultation that he had gone to Hyderabad to see a very serious comatose patient who was admitted with Dr. Subhash Kaul. And coming out of the ICU, he explained everything. And Subhash was there. And then one of the relatives asked him that she was a lady of 35 or something. She has got dark circles below her eyes. So Dr. Singhal said, so she asked, what is to be done for this? You take one katori, put some warm water in that, then take a cotton and through each eye do 1, 2, 3. Other eye 1, 2, 3. And that is all. And then Subhash, should we go? So that is a trick, that we have to learn from Dr. Singhal. That how to handle situation. I think he's the best person to learn so many things.
He's nonplussed and you'll never ruffle his feathers.
Yeah.
Okay, Satish, you did the job.
Satish had a very good talk. Satish is another person from where you have to learn so many things. And I think it was a very good session. Entertaining, I believe. But there are so many important things and so many aspects of practice and successful practice. They will keep coming.
Yeah.
And everybody has his own ways of dealing with things, explaining the patients in difficult situations, and how we were talking about MNDs and where you don't have cerebellar ataxias. So my usual thing is that the research is going on all over the world, and I take their mobile number, and when we will get the answer to the research, I will inform you. So they feel very happy about it that the research is going on. I am going to contact them whenever there is an answer to their problems.
Yeah, they do call, but they do call, and you have to tell them that no, it's still not. They're developing, but not yet. Okay, I think good night. We've got tomorrow 9 a.m. We've got a very nice presentation. It's on a very different topic. It's on Parkinson's and balance and vision problems in Parkinson's. It's totally new and it's very nice. I would request everybody must attend it tomorrow 9 a.m. Bye. Good night.
Tomorrow?
Asif Sheikh.
What time today?
9 a.m. 9 o'clock morning. Morning 9 o'clock, Asif Sheikh. But it's a fantastic talk.
Acha, okay. And then 1:30 in Sullivan.
Yeah.
1:30.
Yes. Okay. No, not 1:30. 12 to 1, I think. I'll just check. To make it, so that people are not hypoglycemic, I requested her to start earlier. So it will be 12 to 1. Okay.
Great. Thank you.
Thank you.